Thank you again for coming here. We've got a great panel, and this panel somewhat mirrors something that we did in the Florida House in our Healthcare Workforce Innovation Committee, and some of the members that are here were present at that panel, where we had a real open discussion about some of the challenges to meeting the demands for workforce in Florida, and some of the possible solutions for that. So, without further ado, the way that we're going to set this up today is that I'll make a small introduction. Each of our panel members will speak for 5 minutes and kind of talk about, in their specific areas, how they feel that we can improve workforce access and affordability. And then we'll have a light discussion and, of course, take questions from the audience. So first, I have the privilege of presenting to you a doctor of nursing, Tay Kapanos. She's also testified before our committee, and she's with the American Association for Nurse Practitioners, and she's going to talk to us about advanced nurse practitioners, their scope of practice, what they practice, and also talk to us about what other states have done in regards to their autonomy and their ability to practice. So welcome, Dr. Kapanos. Dr. George Valdez is not just a nurse, doctor of nursing, but he's also a CRNA, which is a certified nurse anesthetist. And he's going to talk to us about the specific area of anesthesia and how we can further expand access and affordability in that area. Mr. Genu Phillip is a regional pharmacy supervisor for Walgreens, and this is an interesting area because he's going to talk to us about affordability and access, not just in the area of the pharmacies and how they dispense our prescriptions, but also he's going to talk to us about some of the access to certain types of vaccinations, and we're interested to hear about that. And finally, we have a very unique opportunity. You know, sometimes in the legislature we talk about the value of having a businessman being elected to the legislature because we understand about business and we understand the regulations of business and what creates jobs. Here we have this amazing ability to have Dr. Pigman. He's a colleague and a friend of mine. Dr. Pigman is not just a legislator, but he's also a practicing emergency room physician. In addition to that, he's a lieutenant colonel in the Army, and he's been deployed overseas on several occasions. His perspective on this particular issue is invaluable. I'm fortunate to have him as my vice chair of the Healthcare Innovation Select Committee, and he's here with us today to give us a very unique perspective and a very objective perspective on what we need to do in the state of Florida to increase access. So welcome to all of you. It's a real pleasure to have you. And Dr. Kapanos, if you would start us off, we'd appreciate it.
Good afternoon. It is my pleasure to be here. In my role, I am Vice President of State Government Affairs for the American Association of Nurse Practitioners. Under my department, we look at what is healthcare legislation, licensure regulation, and patient care across the nation. And so I was invited to be part of this panel to share with you the trends that are happening around the rest of the nation and how we can integrate some of those changes into Florida. I also chair the the State Policy Committee for the group called the Coalition of Patient Rights. It is a group of various healthcare disciplines, nursing, behavioral health, occupational therapy, physical therapy, and others. And their charter is to help patients get access to the provider of their choice and help make healthcare more directly accessible. So I can speak a little bit on those issues as well. One of the things that we are seeing is in the last several decades, healthcare workforce has undergone tremendous change. And this change really enables us to overlap, scale up, and be flexible with healthcare delivery and the workforce. And we're looking at ways that we can use workforce to improve access to care and contain costs. The education of healthcare providers has undergone tremendous change in the last several decades. Healthcare providers are now equipped to provide a broader, more expansive scope of care to patients, and in many cases, that scope of care overlaps and intersects with other disciplines. That intersection makes us stronger and allows us to have more flexibility in our workforce. Unfortunately, that education hasn't always been keeping pace with state licensure law. And we are finding that we are really at a disconnect between what clinicians are able to do and what state licensure law allows them to deliver, especially here in Florida. We now have highly skilled and educated healthcare providers that can provide a much higher level of care than the limited amount of licensure regulation will allow them to deliver. That's a big gap between the care patients could access but what they can get by law. In this gap is a lot of things. For the state of Florida, just to name a few, in this gap between the care they can deliver and the amount they're allowed to deliver by law results in over 250 primary care shortage areas in the state of Florida. It results in 36 medically underserved areas. For those of you who are employers, we're not just talking rural areas. We're talking urban and suburban. We're talking about where your employees live and work and where they can access care. If you are in a medically underserved area, it means your employee may need to wait longer to access care or opt to go to an emergency room or an urgent care where cost of care is higher. It also results in a $7 to $44 million of added costs to the state Medicaid program. Those numbers are dated. That is from a survey done in 2010 by the Florida legislature, and at that time they found that the difference between licensure law between ability of nurse practitioners and licensure law cost the state $339 million across the entire healthcare sector. The first speaker this morning talked about defraying costs. When some healthcare is paid at a different rate, when there is inequity in care, that is a cost shift. Because of those gaps, you as employers are paying more for your employee-based healthcare services. For those of you who are hosting on-site employee corporate health, it means you have to have different hiring and staffing practices. It's driving up the cost of care and creating inequities in distribution. 1/3 of the nation has already closed this gap between what nurse practitioners are educated to do and what state law will allow them to deliver. At AANP, we call that right-sized regulation, and more than a dozen states are looking at right-sizing their regulation in 2014. So what do we mean when we say right-sized regulation? Nurse practitioners are educated and prepared to diagnose patients, evaluate them, order and interpret diagnostic tests, manage patient care, and write prescriptions. They are trained and educated to do that without a relationship with an external provider. So in the state of Florida, when we talk about right-sizing regulation for nursing practice, we're talking about retiring an outdated requirement that mandates that a nurse practitioner, as a condition of their practice, a condition of them being able to provide those services to patients, maintaining a regulated relationship with an outside and sometimes competitive health discipline. Right now, right-sized regulations are the National Council of State Boards of Nursing model language. It is considered regulatory best practice for advanced practice nurses across the country, and it's the model that all states are leaning towards. Just like your driver's license is individually issued in your state, the license for nurse practitioners would remain individually licensed. But just as there are certain rules of the road that apply whether you are in Hawaii, Alaska, Colorado, or Florida, those rules would be the same. Right-sized regulation through the form of the National Council of State Boards of Nursing would help provide a platform where the state could be more competitive and bring more healthcare workforce to the state. Additionally, right-sized regulation is evidence-based, and it's the recommendation of the National Academy of Sciences, Institute of Medicine, the National Governors Association, the National Council of State Legislators, AARP, the Josiah Macy Foundation, the Heritage Foundation, and many others. Right-sizing regulation at this time for the state of Florida would ensure that we have a platform that allows flexible, innovative healthcare delivery and use of the healthcare workforce that would meet both Florida's current needs and needs in the future. Thank you.
Thank you so much, Dr. Capanos, and we certainly have some questions in regards to that coming up. Next is Dr. George Valdez. He's a doctor of nurse practice and also a CRNA. This is a very unique area, doctor, because there's quite a debate in regards to anesthesiologists and certified nurse anesthetists. So next we'll hear from Dr. Valdez on how we can expand affordability and access through certified nurse anesthetists. Dr. Valdez.
Thank you, Chairman Oliva. Like Chairman Oliva said, I'm a nurse anesthetist. I am an advanced nurse practitioner in anesthesia. I have a doctorate degree in nursing practice, which is very similar to JD, who is a doctorate degree in the practice of law, and a PharmD, who has a doctorate degree in pharmacology. My message is quite simple. The laws for delivery of healthcare models within the state of Florida are antiquated. They were written 30 years ago and have not kept up with the time. And because of this, the restrictions that are being placed on advanced practice nurses are creating unnecessary loopholes. They're costing the state a lot of money. Let me tell you how I really practice. So in the state of Florida, I work under two different models here. I work under medical direction, and I work under non-medical direction. I still have to have a physician supervise me. So when I work under medical direction, I work at a hospital. That anesthesiologist is supervising 2 or up to 4 nurse anesthetists, and they have to come in at certain times of the procedure. Make no mistake, though, I am in the surgery the whole entire time. The anesthesiologist may come in at the beginning and may never come in again, or at the beginning and just at the end. I stay with the patient the entire time. When I'm working in an outpatient surgery center, such as a GI center or a plastic surgery center, I am non-medically directed. And so who signs my protocols for the state is then the gastroenterologist or the plastic surgeon. In that instance, the anesthetic is deferred to me. Outcomes, the same. Actually, there are 16 states who have removed supervision of nurse anesthetists, and there are a multitude of peer-reviewed studies that all say the same thing. There are no outcomes. There are no difference in outcomes and safety, regardless of who is at the head of the bed, anesthesiologist or a nurse anesthetist. Whether they're working together or with non-supervision, there are no differences. In fact, there are many scenarios within the United States where CRNAs commonly serve as the sole provider of anesthesia, as is the case within our military. So let's come back to Florida then. So we require physician supervision. True, okay. But however, there is no doubt that by eliminating this illusionary supervision required by anesthesiologists the anesthesiologists are pretty much one of the most compensated healthcare specialists within the healthcare arena. If you remove that supervision, the cost will come down. So what I like to call is, what are these hidden costs of supervision? Very simple. Yesterday, there was a small little study in a facility here in Orlando, a Deloitte initiative to basically monitor how long are the start times for anesthesia cases. Well, if that anesthesiologist has to be at the beginning of all 4 cases to induce anesthesia, there is a delay. That delay was averaged at about 20 minutes. So this is costing surgical time. Surgical time on average is about $60 a minute. Times 20 minutes, times 60 surgical procedures that were done in this hospital. That's almost $100,000 that we could have saved yesterday. So that could have been another removal of a gallbladder. It could have been a replacement of a hip joint. And where does all this money come from? It's passed down to the consumer and to patients. Another hidden cost is subsidies that the hospitals pay the anesthesia groups to maintain these salaries. And these subsidies range anywhere from $120 up to $180, on average $140,000 to $150,000 per anesthesia location. Again, where does the hospital get this money? It's passed down to insurance companies. How do they pay for this? Passed down to the consumers. Right there, we have cost savings while still delivering the same quality care. Increasing primary care consultations will lead to an increased need in surgeries. Who is going to be around? There will be a problem with access. So by anesthesiologists and nurse anesthetists working side by side, all hands on deck, each one of them doing their job in anesthesia, manning their own rooms, you are meeting this workforce demand and doing it at a cost-effective manner while not duplicating services.
Thank you, Dr. Valdez, and certainly have some additional questions in regards to some of the comments that you made and some of the things we heard during our committee when you had a chance to testify there. Next, we have the opportunity to hear from Mr. Genu Phillip. He's with Walgreens, and he's a regional pharmacy supervisor. Walgreens, to their extensive network, is one of the largest providers of pharmaceuticals throughout the nation, and more they're becoming caregivers through nurse practitioners and minute clinics and whatnot. They also do some immunizations, and Mr. Phillips is going to talk to us some about that and how that increases access and affordability. Mr. Phillip, welcome.
Thank you, Chair Oliva. So my name is Genu Phillip. I'm a pharmacy supervisor for Walgreens. I'm stationed out of Jacksonville, Florida, and I oversee about 40 stores in Northeast Florida as well as Gainesville. I'm also a member of the Board of Pharmacy here in the state of Florida, so with a few different things, and I have different hats that I wear. With Walgreens, one of my primary roles is now around looking at the transformation of community pharmacy. And the role on the state board is with protecting patient safety and protecting the public of the great citizens in the state of Florida. So one of my objectives today is to really talk about the value of the pharmacist and the ways that pharmacists can be part of the solution. So this morning, Dr. Keckley talked a couple of things I want to reiterate is focus on outcomes and how pharmacists can really change outcomes for patients. In addition, talking about balance between treatment as well as preventative care. And pharmacists can be a solution towards the prevention portion of what we're talking about in terms of balance. In order to do that, we have to look at giving the proper support for pharmacists so that they can do these things that we really want them to do in practice at the highest level of their license. So some of the things that pharmacists can do that currently you look at what do pharmacists do? This past weekend, I asked my daughter, who's 15, what do you think mom and dad do? And we're both pharmacists, my wife and I. And so what do we hear? It's, well, you stand behind the pharmacy counter and you count pills, right? And that's the viewpoint of many people in the public, as well as in the industry, as well as payers. And we don't recognize that pharmacists went to school for anywhere from 6 to 8 years sometimes to get a license. And they have gone through advanced clinical training, and we're not using that resource and using the resources that we have. So they can do things around preventative care like immunizations and health testing. They can manage complex medication regimens. They manage chronic conditions. They look to minimize adverse events. And they can support adherence programs. So I want to talk about chronic care for a second. So you think about what Nancy Green talked about during lunch, right? Right now we have 75% of our annual healthcare spend is on patients with chronic conditions. 44% of patients have a chronic condition, 26% have multiple chronic conditions. So we have a 50% growth rate in cancer, diabetes, mental disorders, 40% growth rate in heart disease, 30% growth rate in hypertension by 2023. So all that's going to do is increase the cost of healthcare. And then she also touched on a shortage of physicians. By 2015, the American medical colleges estimate that there's going to be 63,000 fewer physicians that are needed. So again, this is where pharmacists can be a part of that solution to help work on prevention and management of these chronic diseases that are costing the American society much money. So we expect to have, because of the increase of pharmacy schools, we expect to have an additional 46,000 pharmacists in the workforce by 2018. So we have to work on changing that viewpoint. And the other area that pharmacists provide value is around access. If you look at where pharmacists work, they work where you live, right? And the CDC cites that access is one of the major challenges around chronic conditions, right? Patients visit pharmacies more than any other healthcare setting, on average twice a week. So they're in a prime setting to work on preventative care, like immunizations, counseling, MTM services. As an example, diabetic patients visit a pharmacy 30 times over the course of a year versus a physician, which is 2 to 4 times a year. So that's access. 27,000 pharmacies across the nation, pharmacists across the nation are available at Walgreens. We have 8,500 points of care. So we recognize the impact that pharmacists can make on chronic conditions. And in addition to the standard training, Walgreens pharmacists get advanced training around MTM and around patient counseling on chronic care management. Tied with this is the issue of non-adherence, right? So we spend right now in the state of Florida $24.2 billion on non-adherence. That's $290 billion annually, nationally, that we spend. So where can pharmacists really provide value is talking about non-adherence. In order to do all of this, pharmacists need the proper support with the right number of technicians that they can actually supervise. So if we're going to have the outcomes that we want, which is better health care for our patients, we need to make sure that pharmacists have the correct amount of support. Here in Florida, the ratio for technicians to pharmacists is 2 to 1, and we can request an exception of 3 to 1. We'd like that to expand to no ratio, where technicians and pharmacists can decide they can supervise as many technicians as they can safely supervise. The concept of technician ratio is antiquated, and it no longer applies in today's practice. So these arbitrary ratios were put into place to protect the public, but we have 17 states now that have no ratio at all, and we don't see any increase or change in safety with that. So eliminating the tech ratio will allow the pharmacists to be able to practice at the highest level of their license, which will allow our patients to get the greatest access to care as well as lower costs.
Thank you, Mr. Phillip. And $22 billion is a large number. We'll challenge you on how we can actually make that savings in just a minute.
Sure.
You know, if we had a panel made up of a lieutenant colonel from the Army and emergency room physician and a legislator who's a vice chairman of a healthcare committee, that would make a pretty good panel. We have the ability to have that wrapped up all in one person. And I'm very excited to hear his perspective on all of this because of all the areas that he's seen it from. So it's with great pleasure that I introduce Dr. Lieutenant Colonel Vice Chairman Pigman.
Thank you, Mr. Chair, and thank you for those kind words. But in a point of honesty to the audience, I'm just a country doctor, and I'm a boots-on-ground kind of guy. And my message is this: shame on us. Shame on us. Florida has been a leader in innovation in agriculture, in business, and in education. And we've seen fantastic gains in each category. And in fact, we have a tradition of continuing that innovation. We don't rest on last year's gains, we work to improve beyond that. But in healthcare, for whatever reason, in healthcare, we lag. We don't just lag. When it comes to how we deal with our advanced practice nurses and our certified registered nurse anesthetist, we rank 50th of the 50 states. How could that be? In a state that's so proud of its education, so proud of its agriculture, so proud of its business, so proud of its tourist industry, we could let that important industry languish. You've heard important testimony from these very three smart people telling you about the hindrances they face. Well, here's what drives me. We are blessed with an aging population. If we all died at 50, this wouldn't be a problem. I wouldn't be here. But we're blessed with a longer lifespan. It's an aging population. It's a fantastic problem for society to have. At the same time, we're dealing with a healthcare workforce that isn't keeping pace with the needs of the future. It's just not primary care, although that's perhaps where the lag is greatest. We're not producing primary care physicians. We're producing a very small number. The amount we have today compared to the population will be the best we will have it. We will look back to this year, 2014, and say that was a good day. We had fantastic staffing in 2014. We're simply not going to produce enough family practitioners in general practice internal medicine to meet the primary care need. But it's all physicians, all specialties. All of our healthcare needs, as we currently have things arranged, will not have sufficient manpower to provide that care. So that's a demographic reality. You can't ignore it. Now, the second thing that drives me is safety. We've heard a lot of prejudicial talk, comparing one group to the other, alleging unsafe practice in some and safe practice in others. I will tell you that after a careful review of the literature, the data that's published, there is no difference in safety. There is no difference in death. There is no difference in complication. The advanced practice nurse does as good a job taking care of chronic medical illnesses as a family practitioner. Now, it may be that the advanced practice nurse spends more time with the patient. There may actually be additional benefit. With regard to anesthesiologist physicians and certified registered nurse anesthetists, there is no difference in the data. These are huge studies of over 2 million cases that were case controlled. These were the same patients statistically. More importantly, those studies were looking for a difference, and they failed to find a difference despite 2 million cases studied. There is no difference. Additionally, we'll pick on Dr. Valdez over there. Anesthesiology is a pretty technique-intense field. Now, I'm a reductionist. All those boys ever do is put tubes in things. Whether it's a needle in a vein, a needle in an artery, a needle in the chest, a needle in the throat, a tube in the throat, tube in the stomach, tube in the bladder. And in that circumstance, it's who does it the most. And I would submit to you, it's the CRNA who's located in one room all day long, seeing case after case, who probably has the better skill set. But we're not here today to talk about better. We're here today to talk about equal, that safety is equal. Now, there's a lot of prejudicial talk, but there's no data that supports it. And at some point, we, Florida, need to move beyond the jingos, the headline phrases, the boogeyman scaremongers, and do decisions based on data. And the data shows safety. If there's a recent study that shows otherwise, please bring it to me. I will look at it critically. And the final point, Mr. Chair, thank you. I've spent a fair amount of my time with the military. Initially Navy, with the Marine Corps, now Army. I saw the light. No, I apologize to the folks in the Marine Corps. But my point is this. In those deployed circumstances, we all worked side by side. Yes, there was a commanding officer. Commanding officer wasn't a physician. It was an administrator, just like the administrator of the hospital is an administrator. But we worked collegially. And in fact, most of the patients in the clinic, with their cough, with their runny nose, you go, oh, that's a cold. Well, it might have been Q fever. Who knows what might be coming up from the dust in Iraq. Those are advanced practice nurses. And I'll tell you what, when I showed up in Mosul, I didn't know very much about Q fever, Coxiella burnetii, but we learned together. The fact that I've been a physician for 30 years, there's still stuff to learn. There's no guarantee that I know anything. And when we had a blast trauma case come in, it was the CRNA who was looking for vascular access above where the blast trauma was. It was those people putting in the central lines. It was a CRNA who intubated. Now, there was an anesthesiologist there, but the hands on the patients were the young CRNAs. And I think we see this on the civilian side with military hospitals and Veterans Administration hospitals. They recognize the absence of any safety concern. They recognize the wonderful contribution each category of provider can provide, and they're in the forefront of removing hindrances that prevent each category from working fully. So, Mr. Chair, I apologize, but once again I emphasize, shame on us. We can do so much better.
Thank you so much, Dr. Pigman. Thank you, yes.
They must be Chair Hudson's people.
It really is a rare opportunity when we get a chance to have a policymaker that has such a very direct experience in the area. And we have to take special advantage of that during our time in the legislature and make sure that the policies that we pursue are those that are most in line with reality. So let's start our questions with a couple very specific areas. So we've heard some generalities about each of these different areas. We've heard a lot about the overarching type of savings and whatnot that we could have. But let's get to some very direct, boots-on-the-ground type realities. And I'm going to start with Dr. Valdez, because there's been a lot of talk about specialties, and in particular, CRNAs. So the idea is that an anesthesiologist needs to supervise your activity, because while during a routine procedure, you're perfectly suited to handle it, in the event of an emergency, what is being referred to as the rescue rate, in the event that a rescue is necessary, you may not be entirely appropriate to save that patient. Now, Dr. Pigman has talked extensively just recently about the fact that the procedures are mostly being done, intubations of all sorts are being done by nurse anesthetists. But I want to, just for a point of clarity, so in a hospital situation, you would most likely be supervised by an anesthesiologist. The protocol says that you must be supervised by a physician. So an anesthesiologist would be there in the event that there would be an emergency. But let's say that I'm having an endoscopy, or that I'm having laparoscopic knee surgery, and I'm in an outpatient center. Typically, there is a nurse anesthetist and there's a physician. Is there also typically an anesthesiologist in that scenario?
No, there's not.
So in the event of a surgical procedure that is either cosmetic surgery, laparoscopic, or an endoscopy, and a situation does happen that requires a rescue, who's in place to do the rescue?
That would be the nurse anesthetist.
And this is going on in Florida throughout the state
This
today.
is going on in Florida throughout the state, yes. In Florida, and I'm very glad for the question, actually, because in Florida, CRNAs can work basically non-medically directed. I work non-medically directed. I work in a lot of plastic surgery centers, and I work also in a GI clinic. Whenever there is an emergency situation, I am there to respond. And in lieu of my training, it is well within my scope to do so. Because of my background, I am educated in pharmacology and physics and chemistry. I am taught how to take patients from a healthy state and put them under anesthesia, which is what we so call an unhealthy state, and bring them back. This is what I do every day. So doing this in an outpatient surgery center is not any different than doing it in an OR. And in an OR, you're absolutely, and I mean OR operating room, you're absolutely correct in the assumption, yes, there is an anesthesiologist who is supervising, but that anesthesiologist may be supervising 4 other rooms. The anesthesiologist may be in an OB floor. And so if there is a rescue, I am the one who is doing that rescue. By the time that anesthesiologist goes to the GI center at a hospital, let's say that they are doing a procedure and the patient emergently needs to be intubated. By the time they get to me, more than likely, the patient will be intubated already and stabilized, because this is what we do.
So in the event of a laparoscopic surgery and endoscopy, who is your supervising physician?
In the event in a hospital,
currently under Florida statutes right now, who supervises you in these scenarios?
A physician.
When you say a physician, is it an anesthesiologist, somebody that understands your area of medicine?
In a hospital, it is an anesthesiologist. For the most part, there are certain hospitals where it may be a physician because there is no anesthesiologist. That is why I'm saying a physician. The common practice within the state of Florida is a anesthesia care team model where there is a anesthesiologist and nurse anesthetist, but that is not in every hospital in the state of Florida.
So for cosmetic surgery or laparoscopic surgery, would the supervising physician be an orthopedic surgeon?
It may be, yes.
So they concurrently sign off?
They will sign off on my protocols, yes.
And-
And they
and-
delegate the anesthetic to me.
And you are fully in charge of that anesthetic?
I am fully in charge of that anesthetic, yes.
That's an interesting point, because I think that a lot of the concern is that some of what is being proposed would unleash nurse anesthetists throughout the state, and that they would be performing now outside of a supervision. But it seems to me like you're already performing outside of that supervision, and we're basically just keeping that protocol. What would you say is the value of having an orthopedic surgeon sign off on your work as a nurse anesthetist?
The value is you are not duplicating anesthesia services, and you are basically reducing cost overall. There is a cost attached to supervision.
So the doctor that is performing orthoscopic or laparoscopic surgery or an endoscopy, he actually gets part of the revenue
No.
that comes from anesthesia?
No, he does not. If it's an anesthesiologist, they do. If it is a physician who is not an anesthesiologist, they cannot bill for anesthesia services. Anesthesiologist bills for anesthesia services.
So that would probably explain why a lot of procedures are moving outside of the hospital and outside of that scenario to reduce the cost of anesthesia.
This would be correct.
Well, that's important to look at, because that's a real-world scenario of what's actually taking place day to day in the real world, and it's happening right now. And so when we talk about patient safety and the possibility for patient risk, we have to first fully understand what is currently going on. So with that segue, I want to talk to Dr. Capanos. Let's talk along the same lines. Give me an idea of what is going on today as far as how you practice and what kind of autonomy you have, and what this current supervision really means today in the real world.
You know, I think that is a phenomenal question, and one of the things the nursing community wants to bring to this is transparency. The word supervision to most lay people and people that are new to this conversation is that there is someone standing over you, supervising you, dialoguing with care, and being invested in that patient experience. The reality in Florida is that's not the case. There is a signed document between a physician and a advanced practice nurse practitioner, that authorizes that nurse practitioner to do advanced practice nursing in the legalese of delegated from the physician. But the nurse practitioners in these settings are seeing patients independently, caring for them independently, ordering diagnostic tests, initiating care plans, writing prescriptions, and in many cases, the physician doesn't know that those patients were even scheduled or seen. There's actually nurse practitioners in the state of Florida that are entrepreneurial. They have their own practice sites that are separate from the physician, and they are miles away, and the physician's not engaged in that care at all. So the nomenclature that supervision equals safety really is not appropriately applied. And it is a bureaucratic challenge for many practices to open, to improve access, and at any particular moment, the nurse practitioners who have their own practice in the state of Florida, should that physician sell their practice to a hospital, opt to get out of that supervisory arrangement, retire, that entire practice would close. One last tiny point on that, I spoke with a entrepreneurial NP when I was in Tallahassee. He has a practice of over 10,000 patients that he manages, and if at any point the supervising physician under Florida state law opted not to continue that relationship, all 10,000 of those patients would no longer have access to care, because the moment that happened, all that care that was being performed truthfully, unsupervised, and autonomously could not happen.
Okay, so let me ask for some clarity on that, because those are some large numbers. And when you talk about some currently entrepreneurial nurses that have their practices but have this supervisory arrangement, give us basically a rudimentary understanding of how this happens daily. So this nurse has this practice. People come to see him or her in that practice, but there's a supervising physician. Give me a very low-level view of what the supervising physician does.
Signs a piece of paper declaring that the nurse practitioner has the ability to perform certain procedures and write prescriptions.
Okay, so, but this is done on a daily basis, so 10 patients come in during a day, and the supervising doctor signs off on everything that was seen. They sit with the nurse, and they talk to him or her about give me an idea of how it happens.
There is no contact required between the supervising physician under Florida law and the nurse practitioner to provide that care. So on the day-to-day basis, those entrepreneurial NPs that I'm sharing about open their practice, see their patients. At the end of the day, they chart, they bill, they work with their staff, they close the office, they go home. There's no physician involvement in that clinic or in that day-to-day care of those patients.
What is the requirement for the supervising physician? What is the requirement as far as a presence or an understanding or a review of all these different files?
Under Florida law right now, it's a protocol, and that is determined between the nurse practitioner and the physician. So there is not a you must be on site requirement or a requirement for formal chart review.
So this is decided as a private party arrangement. This is not a matter of Florida law.
It is a matter of Florida law in that a nurse practitioner cannot practice unless they have a formal agreement with a physician.
And you said earlier that in our more rural areas, this happens very often where nurse practitioners basically run an entire office. What is the distance, at least, what is the proximity of the supervising physician? How far does he or she have to be from the nurse?
I do not believe that there is a current geographic limitation on that. We do find that physicians self-limit. If they are going to be in these relationships, they want to have some sort of closer connection. And we do hear from nurse practitioners in the state of Florida that to get a collaborative agreement, to get a supervisory agreement, they are required to be an employee of the physician, pay the physician a set dollar amount for the year to serve in that capacity. We have heard certain nurse practitioners share that they have to pay that supervising physician a percentage of their billable income annually. And in one really egregious case, a physician asked for sexual favors in request to have a collaborative supervisory agreement signed.
I have 52 comments on that particular thing that I'm going to hold to myself, but it's not easy to keep that back. But so now let's talk about pharmacology. So Walgreens is a large dispenser of prescriptions. You said earlier, you gave out a bold number. You said $22 billion in healthcare costs. How do you feel that what you are proposing as far as a greater ratio of pharmacy techs or an unlimited ratio of pharmacy techs, talk to us first about how that could actually turn into savings and how that applies to that $22 billion, and also talk to us about patient safety in regards to that ratio, whether it's 3-0 or unlimited.
Okay. So if you look at where pharmacists can provide that value and save money, it's primarily through counseling and education. MTM services is a big factor around this. This is where pharmacists counsel patients. There's 2 areas around MTM. Medication therapy management is what we refer to. And this is where a pharmacist does a holistic view once a year. They allow the patients to review all the medications, and they level set the medications with the patients. They create an action plan with the patients. They look to identify opportunities for changes in therapy, lower costs. Then there's the targeted medication review, where they do this occasionally when they identify gaps in care, and they contact the physician, collaborate with the physician to look to either change therapy or provide counseling to help make sure that the patients are either taking the right medication, identify duplicate therapy, looking for gaps in therapy. So there have been studies around those MTM services, multiple studies that have been done around the country. As an example, in North Carolina, there was a study with CheckMeds that involved 15,000 seniors, saved nearly $10 million in healthcare costs, and avoided numerous healthcare problems. That's an estimate of $8 in savings for every $1 in fees that was paid, and that includes the administrative fees. So that's how we can change that. There was another study in Iowa with MTM services that showed a savings of almost $1 million in 6 months. So you look at, if you think about expanding MTM services, in order to do that, you do need pharmacists to be able to have that time to provide those type of services to patients. And the time is provided by taking away tasks that pharmacists don't need to do. So if you think about what does a pharmacist do inside the pharmacy that they don't need to do, right? And there are a lot of things that we can give on to technicians, but because we're limited to that ratio, we're not able to do.
Well, give us an idea of what technicians do. Give us an idea of what kind of training do these pharmacy technicians have if they're going to be handling our prescriptions.
Sure.
What kind of training do they have? And also, because Walgreens is a national company, give us an idea of what other states look like and what the results have been there.
So as we talked about, every state has its own rules around technician training. Here in Florida, it was instituted that technicians have to go through a board-approved training program. And and every technician has to be registered as well. So that's a difference from where we were before. So that technician training involves something that the board has to approve, the Board of Pharmacy. With Walgreens specifically, every person that comes through Walgreens has to go through ASHP, which is a national accredited technician training course. There's also technician training programs all through the state of Florida that are board approved that they can go through as well. And so with that, these technicians end up being a lot better prepared when they come into the pharmacy department to be able to handle the non-discretionary and administrative tasks that pharmacists don't really need to do. So, and if you think about, just counting pills, doing inventory type tasks, data entry, those are non-discretionary tasks that a pharmacist doesn't need to do.
So, but these are real prescriptions. These are controlled substances. We obviously have a small ratio here that's entirely geared around patient safety. What are the ratios around the country?
So we have 17 states right now that have no ratio at all. And we've done a study with Walgreens to check to see, and since we're in all 50 states, there's no difference in error rate between our state, which has a 3-to-1 ratio, between states that have a 1-to-1 ratio, where there's one pharmacist per one technician, or states that have no ratio at all. So what that tells you is that the rate limiting step in the process is really the pharmacist. Every prescription still needs to go through that pharmacist that's on duty. I would challenge any person in this room to ask their local pharmacist, have you ever had too much help? I've never met a pharmacist that says, I'm sorry, I've had too much help. Go home. It doesn't happen. When errors occur and safety problems occur, it's because you don't have enough help. That's really where that happens. So give the pharmacist the support, and they can do a lot more things and be able to practice at a much higher level and end up saving a lot of costs in that process.
So what is that magic number? So some states have no limit. Mm-hmm. So no limit basically opens it up as it mentions. There's no limit. What's the magic number? What do you mostly see around the country as far as that ratio?
So let me ask Dr. Pigman. So Dr. Pigman, how many people do you think you should supervise? What's a safe number for you? Do you think
Dr. Pigman has an amazing capacity and could probably supervise 100 people?
And you don't need to answer. My point, the point I was making is that physicians don't have a ratio that they have to deal with, right? Why is it that pharmacists can't choose to decide what is safety that I can practice?
Well, because my concern is as a legislator that if I go unlimited, am I going to see a Walgreens that is a super Walgreens and there's 50 pharmacy technicians and one pharmacist? I mean, or what are we seeing?
No, that's not the case. The business model of each store will determine what I can support. If I'm filling 100 a day, I may only need to staff one technician. If I'm filling more than that, I will be able to then decide, based on my business model, how many technicians I can safely support and manage as a pharmacist.
Okay, and you threw out the number of 22 billion. So allowing more pharmacy technicians is not going to reduce our healthcare budget by 22 billion.
Correct.
In the past couple of years, pharmacies have sought to increase their access through the minute clinics that they're called, and also through immunizations.
Yes.
Give us an idea of why these immunizations at our local pharmacy increases access and affordability.
Okay, I appreciate that. So right now, if you look at Walgreens, Walgreens is behind the U.S. government is the nation's largest provider of flu shots. So last year we provided over 9 million flu shots throughout the nation. If you look at just last year alone, during that flu outbreak that we had a year ago, there were Americans lost 230 million working days. That's an estimated cost of about $8.5 billion. So if those individuals had gotten flu shots, and we could have looked at preventing many of the costs associated with the flu outbreak. In addition to that, if you look at access, and we talked about access earlier, 1/3 of patients who receive flu shots got them after 5 o'clock on weekdays or on the weekends, which is when your physician's offices are primarily closed. So this is where the opportunity for patients who work during the day, when am I going to be able to get my flu shot? And when am I going to be able to get any immunization? And why is it that I need to have, I'll tie in my kids to this, right? This past weekend, I took my kids over to the healthcare clinic at Walgreens so that they can get their flu shots. If my pharmacist could have given those flu shots, because they're under 18 here in Florida, they're not allowed to get flu shots from pharmacists. So unfortunately, I waited because I couldn't take them down to the local store where I live, which has pharmacists that could give those flu shots. So this is something that if we lower the age for pharmacists to be able to administer flu shots, then we can increase the vaccination rate, not just in the adult population, but also in children.
So one last question on that. Is there a difference between the price of one of these immunizations at one of these Walgreens clinics or CVS or any of the others? Is there a difference between the price there and the price at a doctor's office?
I couldn't tell you exactly what the price is at a doctor's office. I've never seen that. So I can tell you that it's going to be very competitive. As far as I know, the price that you would get at a pharmacy is going to be less expensive than you would get at a physician's office. I can't see it being lower. Let's put it that way.
So you feel that the savings is more a matter of access to these immunizations rather than strictly the cost?
Right. It's not the cost of the vaccine. It's the result of what happens when people get the flu. That's where the cost is associated with. It's from the hospitalizations that occur. It's from the deaths that occur from the flu, and it's from missing work that occurs in terms of socioeconomic costs.
Thank you, Mr. Phillip. Dr. Pigman, so now we've heard that nurses are currently practicing autonomously with agreements from doctors that may or may not be in the vicinity. We've heard that nurse anesthetists are practicing mostly autonomously in different types of physicians' offices that are not trained in anesthesiology. And we've heard that there could be increased access to immunizations outside of the doctor's office. You're a practicing doctor. Why are you holding on so tight to this?
I know, it's a terrible thing, isn't it? It's worth a minute thinking about the word supervise. To answer your question, if I'm with one medical student or one advanced practice nurse, that's a lot to supervise. But that's an educational circumstance. These are students. And if you're supervising appropriately that kind of person, you're both going to work slower than either one of you would, because it's a teaching opportunity. It's instructional. And I think when the business community hears the word supervise, that's what you're all thinking of. Supervision exists as an argument for only one morally acceptable reason, and that's predicated on safety. Any other argument which supports supervision, I think, is just guild management or rental. So let's think about this for a minute. We had Dr. Kapanis tell us, and I do this, by the way. I don't want to say I'm guilty of it. It's what we do. We signed the chart at the end of the shift. Now, y'all got to be thinking out there, if you're in business, how did that influence the safety one way or the other? Because the patient's long gone. So it's not a safety management tool at all. Now, I'll be blunt with you. We do it that way in the ER because we can bill more for the care. And when Dr. Valdez talks about surgical procedures, well, sometimes I'm the supervising physician of the CRNA's activity, especially if we're trying to put a hard hip back. We may need a little sedation to get that hip back in. I'm the one supervising the CRNA. You know, on a busy day, I may intubate once or twice. Although, to my honor, they all have full stomachs. So I get dirty. He's going to be intubating at least 6 or 7 times a day. I may give sedation for a procedure once a shift. For him, it's his career. But yet, in that circumstance, I'm supervising. Now, we all need help. To do away with supervision, there's another little rumor out there that we're all going to practice autonomously. The heck with everyone else. I'm not going to ask anyone any questions. I need help all the time. And I consult with professional colleagues in a collegial fashion. That process will continue. Why would it not? Why would it not? Of course that will continue. But this notion of supervision is not what those of you who aren't in healthcare think it is. It does not enhance safety because it's not done in real time. It does not enhance safety because oftentimes a supervising physician has less knowledge and less skill set than the person being supervised. And I think safety is the only moral acceptable argument for supervision. And you can tell already that's not what we're doing.
Thank you, Doctor. I think we have a few minutes for questions. Speaker Feeney, great to see you. Speaker Feeney has a question. Please, come on up. Oh, we've got time for one question. Very good.
Oops, we went long.
Yeah, we did.
My name is Ed Briggs. I'm the president of the Florida Nurses Association, so I'm jaded into the conversation. But I will take the perspective of my physician colleagues. Many physicians would say that healthcare should be led by a team leader, and that team leader should be the physician, and everyone else should work under that leadership of the physician, and that removing protocols removes the physician from being the leader in the care, and therefore compromises safety. How would you respond to that?
Well, I'd like to have Dr. Capano's response to that first, and when we could let Dr. Pigman, who is a physician, respond.
You know, I'm really glad that you asked that question. I didn't ask you to, but I wish I had. I think the group that is in most opposition to allowing patients full and direct access to advanced practice nurses and other groups uses that argument, and I think unfortunately they are blending and braiding two very distinct and different concepts that need to, for the sake of patient care and regulation, remain separate. Licensure is about ensuring that an individual person meets baseline competency requirements and licensure to safely deliver care to patients. The other is about a mechanism of coordinated team delivery. They are very different, and I think if licensure-linked team care, which is what Florida and the majority of the South have right now, was the solution for healthcare workforce improved outcomes, the South would be leading the nation in health outcomes, team-based care delivery models, and driving down cost. That's not the case. So we know licensure-linked team-based care is not a solution. One other tag-on point to that is the IOM wrote a paper on team-based care saying what principles should be in it. There are 6 core principles: mutual respect, communication, shared goals, patient-centeredness. Please forgive me, I'm not remembering all of them, but one important point that the IOM intentionally left out was licensure-linked teams. They didn't think that was necessary, and the IOM group went further to say, team-based care is expensive. Please make sure you're deploying it where the outcomes are going to make the most difference. One of the authors talked about healthcare teams being like a symphony or playing music. There are times when a soloist is all that's needed. There are times when a quartet is needed or an ensemble, and then there are going to be times when you need that full orchestra to meet the needs of the patient. The legislature and the licensure component is not a place where we should be determining what type of ensemble or full orchestra is needed. We need the licensure component to be about individual licensure criteria and safety for patient care, and then allowing flexibility and innovation within the healthcare community to determine the models of team care or coordinated care or whatever platform works for that community and that setting for which the care is being delivered.
Dr. Pigman, we've just got a couple of minutes. Same question. Team care, physician should be the team leader. What do you say?
Horse manure. It depends on what factor, what you're trying to accomplish. In the emergency department, the team leader is the charge nurse, right? The charge nurse knows what rooms are occupied, what patients are in what rooms, and it used to be Senator Grimsley. She knows where to send her resources to get the most return. In that circumstance, the charge nurse has the data and the skill set to be the leader. In an office-based practice, it's going to be that person who understands throughput of the patient, the laboratory processes, the x-ray processes, and the various personnel. That's not necessarily going to be a physician.
Or an advanced practice nurse, if I might add.
Yeah. In other words, the team leader is the one who has to look at the entire skill set of the people with them and marshal those forces to accomplish the problem at hand. It could be a physician. It could be an advanced practice nurse. It could even be a pharmacist. But the point is, the leader has leader skills. And there's nothing in any of the titles we've heard so far that guarantee that that person, because of the initials after their name, have leadership skills.
Thank you, Doctor. Well, that wraps up our time. Thank you so much for the panelists for such a great discussion.